الدكتور حاتم ناس درتك حتى انت كو هوست بريكومنديشن من ايمن واسطه قويره. خلاص خلينا نبدا في التقديم. بسم الله والصلاه والسلام على رسول الله. اهلا وسهلا بكم. احنا في بسم الله والصلاة والسلام على رسول الله. أهلا وسهلا بكم. احنا في اللكشر سيريز تبع جمعية القلب الليبية، الانترفنشنال كارديولوجي لكشر سيريز. اليوم نبتعد شوية على ستنتس والكاث وحنركزوا على الأذر سايد of revascularization which is an extremely important side اللي هو البايباس سيرجري. أنا كانترفنشنال كارديولوجيست ندير في ستنتس، وكان ما نقدرش ندير ستنت نحول للسيرجري وتكون القصه تمت. فبنسمع اليوم من دكتور عادل ديوب شنو هو الباي باس سيرجري، وات داز ات انتيل، واتوقع يعني حتكون محاضره شيقه. دكتور عادل ديوب يعني غني عن التعريف، اللي قاري في كليه الطب طرابلس، بعده شيتات الديوب كلنا يعني قرينا منهم واستفدنا منهم. فهذه بروح الاجر نتاع الشيتات نتاع cannot be شو اسمه يعني discounted. بعد التخرج في الطب من جامعة طرابلس دار دار cardiac surgery residency في هاملتون، currently he's on staff there ودكتور متميز الصراحة، فمحظوظين جدا أن نسمع منه اليوم. بس يعني هاوس كيبنج ايتمز عادة لما تقدم لو شفت ناس خاشين متدورة جنيه وايمن حنديروا لهم enter the room. حاليا there is no ability to unmute yourself. يعني لو انت تبي تتكلم عندك سؤال اكتب في الشات باش تكون الحكايه منظمه شويه. وتفضل عادل.
اوكي just gonna put the timer. عندي ساعه يعني ولا تقريبا
يحاول حتى 45 minutes كويس باش يخلوا وقت للسؤال. لكن
والله يوم سلايدز هلبة، لكن انا طبعا بنحاول control myself as much as I can, so I will have a okay. Shukran Bassem, thanks for everybody for attending these lecture series. I think they have been very successful, and I think I've been enjoying and learning from all the previous ones. And I think this is the first surgical lecture in the curriculum. I was given the task to talk about Cabbage. Cabbage is a very big topic. I think we all know, and I will try to cover as much as possible to give simple basic principles, but also will not prevent me from diving in some details when needed. But I would try to keep it simple as well, and I would probably highlight some areas of which is related to bypass surgery in a very simple format. Okay, so oops. So the outlines of my presentation will talk a little bit on history, natural history of coronary disease, which everybody is probably can learn more from the cardiologist than myself, but we'll just get a couple of slides. Decision-making process and the role of the heart team, and also the conduit choice, role of viability assessment, just very brief. I was asked also to comment on a little bit on off-pump and the indication for cabbages, and also since I do minimum invasive cabbage, I would also have a few slides on this, and we'll probably discuss some landmark paper publications to talk about when it comes to the indication for cabbages. I will start off with probably the best way to leave any impressions or comment on things. I think using a case may be a good way of looking at things. It makes more educational rather than just a dry slides. So this is a real patient from our heart team rounds that we discussed last week. A 64-year-old gentleman admitted with heart failure, had a high BMB. Nothing in the past medical history, was not on any meds, and he had a left bundle branch block, and he had an echo and cath. So here is his angiogram, and you can see his LAD is occluded and is filled by collaterals. He also had disease affecting the OM. Two OMs are diseased. I'm not sure if you guys see, but there are two OMs here that are very clearly diseased, and also has a moderate disease on the right. His echo showed a bad ventricle, and there was a discussion that he is EF around 20%, and whether that target for the LAD is viable or not. So you can see the echo and then the discussion that we shouldn't be offering any intervention at this stage until we get viability assessment, which was done by the MRI, which to my surprise came whole myocardium is viable, and he was referred to me for, and that is a recommendation by about 20 people in the heart team around. So this is an indication of the rules and the value of having a team decision when it comes to deciding for which is the best approach for treating patients. Another patient a couple of weeks ago, I think during a snowstorm, there's a 84 years old who referred to me for a Cabbage, and he is 84. He does have no previous history. He's very healthy otherwise, but had an angiogram that showed good LV function, a very tight RCA, a tight left main, very tight left main, and ostial LAD, disease circ, so disease everywhere, and calcified aorta, and the CT confirmed, and they are still asking you, and these patients will come to you in your practice, and you have to offer them some sort of intervention. And the other thing that I'm going to comment is people always ask about the type of conduit. There's a survey, and I think STS, they surveyed in terms of what would be your choice of using bypasses if you have a patient who's 54, hypertensive diabetic, and dyslipidemic, and he had a left main 70%. What will be your choice of conduit? Are you going to be using mammary and two veins, or mammary and radial and vein, or Lima radial? So you'll be surprised. There's a lot of variety, and people practicing differently, and the response from over 116 responder were almost even, like a one-third. So just to give you an idea on how the practice is different among different places, and the preferences doesn't matter, young patient, older patient. I do believe there's guidelines and there is indications, but also individualized care and expertise is also important. So just go very quickly on the history of Cabbage. I would say this is probably the first one who attempted any sort of revascularization. Dr. Arthur Weinberg, everybody talk about him and knows him. He implanted the Lima pedicle into the LV wall to try to achieve some revascularization. I think he's a Canadian from Quebec in 1946. So over 70 years ago, he attempted to do that. Then a German surgeon who was practicing in the US performed the first Cabbage in a human with Rima to the RCA, but not using some sort of not a suture, something called Roseneck ring in 1960. David Sabstan is the first one who performed hands-on coronary anastomosis in 1962. René Favaloro, everybody knows. I think we have his retractor still we're working with when we harvest the mammary. He performed the first saphenous vein in May 1967. By 1970, he had done more than 1,000 cases using vein graft. I think there's always that debate and fight between the US and the Russian, which is still going until today. Who is first? Who is best? Who was on the moon first? Who invented this first? Who made the nuclear bomb first? The same thing for Cabbage. The Russian will say, we were the first one to perform bypass. In fact, this is one that performed the first off-pump Rima to the RCA hands-on. And then there's another doctor from New York who is in 68, as a year after. I like his quote here. He's the one who populated the use of Lima. Many experts believe that the internal mammary artery often is it's very small vessels, only 2 millimeters in diameter, and too small to use for coronaries. The limiting factor was the eyes, not the hand. So by using the operating microscope, he was able to actually perform this on a routine basis and become the story of the Lima that you knew afterward. Alan Carpentier, who's a pioneer in not only Cabbage, he's also a big mitral valve surgeon. He actually used the radial in the 70s, and because of the poor outcome due to the trauma and the spasm associated with harvesting the conduit, there was a lot of failure, and the procedure was abandoned until 1992. Akar and his group reported improved patency rate and outcome, and that's because of changing the technique of harvesting and the use of calcium channel blocker to prevent spasm in radial grafts. We all know this, maybe he's not his picture, but the name, I think he is the one that saved the cardiac surgery specialty. Floyd Luke from Cleveland Clinic has reported the 10 years outcome with Lima versus vein graft in 1986 at the Cleveland Clinic. And believe it or not, this is the only best study. There's no randomized controlled trial comparing Lima versus others. This is the only study on which is based on what we know now why Lima is good for long term. Because of such a huge magnitude of effect change, the Lima has shown that is so powerful that I don't think people were interested to study it in a randomized controlled trial. So it has shown that it's improving, the use of Lima has effect on improving survival, reduce the risk of MI, reduce the hospitalization, and reduce the repeated revascularization. And these are the four main outcomes that in every study you probably see, and I think that was very clear in 1986. And since then, Lima become in every Cabbage surgery. You can see the numbers of studies being comparing Cabbage and PCI, but we probably will touch upon this later on. Natural history of coronary disease, we all know living with coronary disease is not something without risk, and the risk goes exponential depending on how severe you have. Living with 3-vessel disease with more than 90% Brock's LAD, your annual risk of dying is almost 10%. Living with proximal LAD disease, even if it's a single vessel disease, is about 3 to 4%. So we know that's why we are intervening on those vessels. The risk, of course, is depending on the degree of stenosis, which you don't need me to talk about this. I won't spend much time on this. And I would like to talk about a couple of things related to my field, especially as a cardiac surgeon, which is two terms that I would like people to know about: myocardial hypernation and myocardial stunning. We tend to get this, especially when we operate and we arrest the heart. There's a difference in both, the definition between both. Both of them probably, especially with regard to the time frame, the hypernation is probably more of a chronic condition. It's usually a prolonged impairment of contractility due to recurrent episodes of non-lethal ischemia. And there is actually a change in the cellular level, and there's also a change even at the metabolic level and what to use in terms of energy and stuff. So instead of using fat, it becomes glucose. But the good news in both hypernating and stunning, the myocardium is viable. Myocardial stunning is usually, again, impaired contractility following resolution of episode of non-lethal ischemia. For example, when you put a cross clamp and you arrest the heart, and when you're trying to come off, and you probably go into 6 to 8 to 12 hours of period where the myocardium is not as before. And this is the period where we call the myocardium still stunned. But when somebody lives with 3-vessel disease and has a global hypokinesia, we don't use the word stunned. We use myocardium hibernation, just a bit of differentiation between the term stunning and hibernation. If you look at it, even in terms of recovery, the stunned myocardium usually recover in a day or two. Early hibernation takes weeks, and advanced hibernation may take up to months. Even if you do bypass and somebody whose EF is 30, you don't expect the EF to be 50 next day because it's hibernating. There's a lot of downregulation. There's a lot of genetic changes and at the molecular level, and the myocardium will need time to adapt to the new changes. I'm not the person, but I'm going to mention these are the test modality that they use to assess viability, which I think the most common are the MRI, the PET scan, the SPECT, and also the beta-mean stress echoes. I think this itself is probably a series of lectures, so I'm not going to be spending time here. Just a quick, people always ask me this, and I think it's been a topic of debate in the literature. Still it's not settled yet, and it's not settled because there wasn't actually a very good studies aiming to look at this. Most of the studies that we're hearing and we are trying to apply in our real practice is an extrapolation or a sub-studies from other studies like stitch studies or ischemia studies or other studies. So I think the interaction, the interplay between presence or absence of viability, impact of revascularization when it's done, and how is it impacting the functional recovery and prognosis. This interplay between these variables is very, very important. And some of the answers has been addressed by certain studies to this dilemma, and some were not. I think some people say you don't even need to test for viability. And some people say, well, you know what? I think you need to depend on how your patient, like the case I showed you earlier, none of us in heart team round felt comfortable doing either PCI or send him for Cabbage, despite the fact that he had LAD that is graftable by angio, he had 2 tight OMs, and he had poor LV function. And the decision to refer came only after we did the cardiac MRI that proven to us. So if I want to listen to the literature, I would not have sent that guy because Stitch said viability or no viability doesn't make any difference on long-term outcome. But I think that study, you have to take it very carefully because it was not aimed to address that question. Does the viability predict improvement in LV function? Again, tough question. What do you mean by improvement in LV function? What is to you is important? Is it a 5% change in EF from 20 to 25? Is it a 10%? So it's a very vague question. And heterogeneity in measuring echoes, LV function, who does it? And is 5% is a cutoff? Is it 10%? So we don't know. So there's a lot of questions unanswered in this field. Is the LV function a valid, is the change in the LV function is a valid surrogate endpoint for clinical outcomes? Again, a lot of the literature right now does not tell you that just the LV function, if you follow it, is not going to give you an answer. It's not. Because I think when we revascularize, we not only protecting patient from pump failure, we also probably having an impact on other causes of death, which is namely arrhythmias. And I think most people think if you don't improve the LV function, and that's probably the reason why, if when you look at the Stitch trial at 10 years, those who subjected to Cabbage versus medical therapy, they have improved survival. But when you look at the sub-study of viability, it said whether you have viability or not, it has no changes. Just because people don't die only from pump failure, they could die from arrhythmias or other cause of death that is potentially prevented by doing revascularization. So, and also the other question, the big question, how should we apply viability testing in the clinical practice, which is the question that I asked earlier. But again, I do believe individual medicine and expertise and heart team will be the place to apply this kind of knowledge so that we can tailor the intervention to the patient. I wouldn't waste my time in this. This is a sub-study that I just talked to you about. They said the lack of viability data in all patients. In patient with coronary disease and LV dysfunction, assessment of myocardial viability does not identify a patient who will have a greatest survival benefit from adding Cabbage to aggressive medical therapy. Just be careful not to use this as like this is a class. This is not a class 1. I mean, it is a sub-study. Wasn't meant to be used for assessing. It was meant to assess the LV function and the impact of Cabbage and medical therapy. The method of viability was variable from center to center. There was no standardization of what method to use. So be careful. They only used I think SPEC and Dubity stress echo. We all know the sensitivity and specificity of PET and MRI is much better and has not been used in the study. So you have to be very careful and read these conclusion of these studies with cautions. In fact, if you look at this sub-study published in 2021, 24-month follow-up analysis with Stitch trial, demonstrated a clear association between substantial improvement, put like 3 lines under substantial improvement in LV ejection fraction, more than 10%, and improved mortality. So you talk to most cardiologists, to most cardiac surgeon, there is no difference in the improvement in the EF, or the EF improvement is not have an impact on the outcome. But if you have a subgroup of people who their EF goes more than 10%, there will be association with mortality. Now we'll switch gears to the heart team and the process of decision-making. I think this is a very important topic, and I would love to have our colleagues in Libya to start incorporating it in their practice, because I think it makes a huge difference and takes the load off shoulders of the responsibility on certain people, especially the high-risk patient, when it comes to decision-making. And also it fosters a very good relationship between cardiac surgeon and cardiologist, and it makes the practice, especially applying guidelines and treating patient, will be, we experienced it in our center in the last 3-4 years. We have weekly Friday round where we discussed complex and difficult cases. And I think the feedback and the outcome of patient has been influenced in a very positive way. So it is in the guidelines. So people say, well, we're not going to do it. And it is actually in the guidelines of 2021. So inpatient undergoing revascularization decision should be patient-centered, that is considered of the patient preference, goals, cultural belief, health literacy, social determinant of health, in collaboration with the patient support system. So there's no more one decision-making or, you know what, it's one person who decide. No, you have to consider all the other variables, which I will be trying to dig into this in more details. So basically, it is in the guidelines. And why the notion of heart team came up in the last probably 10, 15 years. I mean, we've seen it in TAVI. There is push for most hospital. Mitral clip, we see it in a lot of other arrhythmia management. There's a lot of push toward heart team. I think our team consists of non-invasive cardiologists, cardiac surgeon, intervention cardiologist, anesthesiologist. In some cases, we get even ICU doc because these are the guys who's going to look after. And I think it makes sense to have ICU doc. In other centers, they have nutritionists, they have cardiac rehab, they have a bigger team. But if you at least start with these 4 people, it will make a huge impact on decision-making. Why we need it? I think it's very obvious reason. There is a lot of equipoise, there's a lot of gray zones in the practice. There's a lot of things that have been done not following recommendations. And the utilization of revascularization in about 18 to 40% in patients with coronary disease. And that's depending on which sources you read. There is an inappropriate use of revascularization strategies. We see it every day. There's a marked variability between PCI to Cabbage ratio. There's no reason or explanation as to why center A has a PCI to Cabbage ratio of 2:1 and the other 7:1. There's absolutely no explanation apart from, I don't know, ego, relationship, preferences. So I think if you have the heart team, then things will be much better, especially in the high-risk patient. One second. This is a paper published by one of our colleagues from Hamilton. It is my name there. My God, I just realized it now. So Michael Sang is one of our intervention cardiologists. He is very into, he's the one who established the heart team. And he came up with a study comparing the decision made by heart team versus just an intervention cardiologist. So he sent us hypothetical scenarios, 3 groups, cardiologist, intervention, cardiac surgeon. Each one look at the variables and decide which will be the best treatment option for this patient. Is it you want to treatment medically, or you want to refer him for surgery or PCI? And you'll be surprised. There was a 30% disagreement. There was a 30% disagreement, and there was a significant difference between the decision between the heart team versus if we let the interventional cardiologist treat the patient according to his own. And their conclusion is there is actually 30% differences. So I think it's worth. I think if you find that, wow, we agreed in 95%, then you say, well, okay, but 30% is a lot. What are the factors influencing decision-making to operate? I think some of it related to the anatomy, left main, multivessel, disease complexity, comorbidities, such as diabetes, liver disease, calcified aorta, presence of other valve disease, procedure factor, local and regional outcomes. I think it's very important if you know that you're a PCI guy, but the next door hospital, every mortality, every Cabbage sent dies, then you have a reason to rationalize your reasoning why not sending him for Cabbage. I think that's a very important thing. Even for the patient himself, they have the right to know the local expertise and the local outcome for each individual procedure performed at the center. So surgical risk is important, PCI risk, patient factor. I can tell you, I'm an example, religious belief. There are people who are Jehovah's Witness, who does not accept blood. People who lives alone does not have a support. People cannot be adherent to dual antiplatelet therapy after PCI because either they cannot afford it or they have a risk of bleed, they have a peptic ulcer or GI bleed, whatever. Patient preference. You can tell whatever you want from guidelines or from evidence. they would not accept opening their chest. So period. Give me PCI. That I don't care. Complex, disease, diabetic, left main, do PCI and let me alone, leave me alone. Patient education is also important, knowledge and understanding. The predicting risk, I think also I want to emphasize the fact that in every patient you see, when you suggest surgery, you should calculate his risk. We use Euroscore, but I think STS score is much more validated, and I think it's much more, even in the guidelines, much more stronger. Unfortunately, it is much more complex to calculate, but the Euroscore is much easier, but at least you get one of the scores to assess the patient profile. There are other things that are not captured in those risk scores when you assess the patient, such as presence or absence of cirrhosis, frailty, and malnutrition. And for this reason, we do have other ways of assessing patient. And I think this is the rule of, like there's a good scale called Frelity Scale. I think TAVI group using this routinely, and it's very helpful to supplement your STS score or Euroscore. There's another one which is called CATS index, independency, to look at patient whether they are independently, feeding, toileting, transferring. So you had a score. If you have a score of patient, like for example, you tell me this guy's score is 9, he's a wheelchair or bedridden, and he's an 88 years old. Doesn't matter what your score it is. It said he's a bedridden, he's a demented, and he's depending on everything for toileting, for feeding, for dressing, for everything on others. I wouldn't offer this guy a surgery. Conduit option. We've had, we all know our options when it comes to bypass. I think I'll just summarize them. Lima is the king, Rima and radial are the second, saphenous vein is probably third, lesser saphenous when you are desperate, gastrobuccal artery, I would not probably mention it, except the Japanese, I think, still using it. I think it's falling out of favor, but there are some Asian countries using it more than, I think, North America. I don't think or even Europe, there's any people or centers big on this. They are in the guidelines. I think use of the radial artery graft recommended as very important when you send patient for Cabbage. Don't get upset if you don't get your radial to your younger patient, but if he has a stenosis of 50-60%, you're not going to expect him to get radial, because radial artery works only if you use it in a 90% stenosis or more. So we like it if it is a subtotally included and it's a nice target. And that is very key. Otherwise, you run into trouble with atretic failed graft early on. Use for somebody who's renal failure is probably gonna likely need a fistula, so try not to use the radial artery. People asked to harvest the mammary with skeletonized technique to reduce wound infection. I think this is something, if you can do it skeletonized, I personally still use a pedicled mammary. I don't use a skeletonized. Endoscopic vein harvesting is preferable in patient with high risk. I did one yesterday, was a 300 pound, and I changed my wound. Like if I have a big guy with diabetes and high wound, I would ask my assistant to take the vein endoscopically. But again, it's just depend on the availability and whether your center support these kind of techniques. Always Lima, try to use it for every case, especially the left system. People always ask Rima. Rima is good. Unfortunately, the latest trial by David Taggart, 10 years outcome, Lima versus Rima is no difference in outcome. There's actually slight, there's significant difference in sternal wound infection. I think the problem with all the studies comparing adding any additional graft other than the Lima is they're going to find themselves in a very big trouble try to prove or show any difference, because I think the greatest magnitude of the outcome effect is delivered by the Lima, because since the Lima feeds the biggest runoff distal target, which is the LED with all the septal perforator, with all the diagonals, it will stay open more than 95% at 15 years, and it supplies the biggest part of the heart. So whether you do Rima to the RCA, whether you do Rima to the circ, it is nice to see your vein or your radial Lima, the Rima does not fail 20 years later. But I think it's not going to be easy to prove that adding any arterial conduit will have. Observational studies could show, But I'll tell you, the best study conducted in comparing Lima versus Rima is by David Taggart from Oxford, and it's thousands of patients. There's no proof at 10 years, even when we prolong the follow-up, that adding Rima would be different. Again, I still use Rima in individualized patient with tight proximal disease and the RCA, or I would do Y graft in some tight big circ, I would do them. But again, don't feel bad if your patient did not get a Rima. Vein graft, if it's done well and patient follow the optimal medical therapy with a good Lima harvested, they should still do well. In terms of graft patency, we all know Lima is the best. I think over 90% will be still open at 10 years. The vein graft patency range between 50 to 65%. I think the factor that influencing the graft patency is the degree of stenosis. We all know that. The target, the left versus right. Usually left system, whenever if you put a Lima, Rima, or vein to the left system, tend to be better than the right, and the method of harvesting. Why Lima is the best? I think it has multiple reasons. We always put it to the best target. It has a very thin muscular layer, so it's very prone to spasm. Very rare to see a mammary that goes into spasm, because even in those bad LV function, inotropes, pose, shocky, if you have a radial, if you have a patient with low EF, and you're likely gonna come off with epinephrine, norepinephrine, just be careful not to use radial in those patients, because you may end up with a string sign and a spasm, and because the radial has a very thick media and muscle layer, so they might be not a good option. You're probably better off getting a vein in and out. The Lima, for some reason, has the ability to have some secretions of some material like nitric oxide that actually helps to vasodilate the vessel itself and keep it open. In fact, it could transmit the same property of the mammary down to the bed and the coronaries, and that has been shown in some of the Japanese study. We talked about this. I don't want to spend much time about why Lima has been proven to be better in the study by the Cleveland Clinic. And when it comes to the use of Rima, unfortunately, despite being proven a good graft, it's not very commonly used. Under 5% of Cabbage in the US uses Rima, and under 10% in Europe. And the reason why it's technically more challenging adds the time to the operation duration. And also we know that if you start using it in a lot of patients with diabetes and renal failure and obese, I think your risk of sternal wound infection will increase. This is the bilateral study I just mentioned. There's no difference. And I think the only difference is a sternal wound infection. And you're talking about almost 3,000 patients. So this is a very robust, well-conducted study, randomized controlled trial comparing Rima and Lima. No differences. I won't spend much on the radial. I mean, the radial is considered the second best conduit. When it comes to off-pump, I think I do off-pump, and I find it every surgeon in training and every surgeon practicing, I think he should have the off-pump skills on his shelf in case of, he's stuck one day with calcified aorta, and I mean, there is still room for off-pump. I would summarize the indication, but mainly for calcified aortas and people with anemia and elderly people. So the purpose of using off-pump when it was introduced is to try to avoid the inflammatory process or response to the cardiopulmonary bypass, and try to cause less renal dysfunction and reduce the risk of stroke and less blood transfusion. But some of this has been proven, some of this has not. But I think for now, we know that comparing Cabbage done on pump versus off pump in low risk, it has no difference between both. And that's why that was proven in the Ruby trial and the Coronary trials, that there's no difference between both. But if you look at those trials, mean age of study of patient were in the 60s. And I think the patient that I just showed earlier at the beginning, 84 years old, and he had a calcified aorta, tells you that you need to not to be only stuck to the guidelines, say, hey, this is do this. There's no difference between Cabbage and on or off. No, there is if you have a calcified aorta, because if you continue and do him on pump, you will kill him or you stroke him. So I think I always tell my resident that you should learn, you should do at least the basics of off pump, even straightforward, maybe just a Lima to the LID in case you really stuck, and you can just do the Lima to the LID let them stent the rest. But the benefit of off-pump require a careful patient selection and special expertise. Not everyone could do this. It needs a special training, needs a special dedication and special attention to details. It's not like when you are on pump. The indication that I am aware of and I do for is calcified aorta, somebody with LV dysfunction, patient with stroke, patient with renal dysfunction, somebody's creatinine 200 and his hemoglobin is 10 or whatever, 100 in our system. I would try to, if I want to try avoid him blood transfusion, I would reserve to off-pump technique. Mostly when we encounter calcified aorta is what I use it for. Or patient who, if you got a patient who is a Jehovah's Witness, who does not accept blood, these are a good option because you avoid the hemodilution from the pump. The contraindication where you cannot do off pump, if you have a feeling by looking at the angiogram, the vessels are intramuscular, don't go there. If the vessels are very diffusely diseased and calcified, if the patient is hemodynamically unstable, don't try off pump. You're just gonna make it worse. You could do pump assisted. You can go on pump, don't arrest the heart, but at least you are on pump so that at least you stabilize the myocardium, you stabilize the heart. If there is any signs of physiologic intolerance, you lift the heart, you try to position, pressure goes down, arrhythmic, very irritable, don't do that. If there is severe cardiomegaly, because I think the instrument that you're going to use, if they're not be able to stabilize and help hold the heart for you, the bigger the heart, the more difficult to achieve certain targets, especially the circumflex and the back wall. It is in the guideline again. I think this is the topic that probably going to trigger some antibodies in Bassem and the rest of the group, but I'll go for it because we are here to discuss Cabbage. I'll see what the conclusion will be at the end. So I have a patient who is 66 years old gentleman, a diabetic with the class 2 angina with EF around 40% with 3 vessel disease. The question is, in diabetic patient with coronary disease, does Cabbage compared to PCI reduce mortality and re-intervention? The second question, in patient with left main disease, does Cabbage compared to PCI reduce mortality and re-intervention? So if I'm a new person or a cardiologist or a GP who's just started or somebody who doesn't know this, so I think it's worth going to the literature and try to find this. I would say, let me go to PubMed or Google, whatever. So I'm going to look if there is any study. So I enter, I look and I say, okay, show me what is, okay. I find Syntax trial and I find Freedom trial, I find Excel trial, and I found Nobel trial. So Freedom is long-term PCI versus Cabbage and insulin and non-insulin treated diabetic. And I found I would say 3-4 good studies to answer my question. So I wanted to go more in details and see, okay, let me see what outcome they're looking for and what time frame, what follow-up, what subgroup, and let me come up with answer to that question that I just framed. So Syntax trial, it's a multi-center trial, 1,800 patients with left main and multivessel, and outcome mortality, CVA, MI, repeated revascularization. And there was no difference in all-cause death. Everybody was happy with that. But I think the main question from this is the syntax. I think when we classify the patient by syntax score more, like the high syntax score is the ones that makes a difference in the outcome. So people would do better with Cabbage. The problem with syntax score has the people with left main, there was some diabetic, and people start analyzing subgroups, this and this, and everybody now from cardiology will come to you, oh, syntax did not show difference in left main. I'm sorry, you only have a 91 isolated left main, my friend. Oh, did not show a difference in diabetic. Oh, I fortunately had only 420 something. So I think you have to be very careful. These subgroup analysis could be hypothesis generating for future study. It shouldn't be taken as a practice guideline because there has been a subsequent studies done to address those questions. So people would ignore the main study addressing question, but say, oh, syntax trial, by the way, showed no difference in left main. Okay, would you believe a subgroup analysis or would you believe the Nobel trial? Would you believe the syntax score or study for diabetic outcome, or you would believe the 8 years outcome of Freedom trial? So that's very careful. You have to be very careful when it comes to interpretation of the studies. So clearly the syntax score more than 32 was in favor of Cabbage at 5 and 10 years. And that was very clear. And again, if you look at the combination of left main with 3 vessel disease, left main with single vessel disease, left main, I mean, it is a very heterogeneous group of people, a smaller group here and there. If you start analyzing, of course, you're not going to see much difference. Yes, there's no difference. P-value, so all nice and B.84, except 3 vessel disease, because you have a probably larger population here. Cabbage is superior. But I just, word of caution to believe those sub-analyses. The Freedom trial, it's to address the diabetic patient, basically. 1,900 patient, PCI versus Cabbage. And they looked at mortality as a primary outcome. You can certainly highlight, I can certainly highlight here the importance of long-term follow-up when it comes to device or any intervention comparison. If there's always a price to pay for Cabbage upfront. If you look at the curve here, look at the curve up. If I looked at the Cabbage outcome at 6 months, Cabbage will look bad. Look at the crossing at less than 1 year. Look at the divergence of the curve. And I bet you it will continue to diverge long term if you keep following. And it's true, right? The outcome at 8 years, still the survival is in favor of Cabbage and p-value is positive. So I think the Freedom has proven that Cabbage versus PCI, I think we all probably know diabetic doesn't do very well when it comes to revascularization with stents. Nobel trial is also addressing the left main question. It's a prospective randomized open label non-inferiority trial. Again, they looked at death from any cause, MI, repeated vascularization or stroke. Again, same thing. If I came here and I said, what is the outcome between Cabbage and a PCI? No difference. Continue follow-up is the key. The Cabbage is superior at 5 years. So Excel trial, same thing, addressing the left main. Here is the question here. Watch the trick here. Primary outcome, death from any cause, non-procedural myocardial infarction, stroke. They took the repeated vascularization out. So this is, as I said, whenever you read these studies, you have to be very careful. Although it's been reported, but when you judge or you base your primary outcome, you will look, sometimes you might be looking, oh, why am different? Because the other studies, they all have repeated revascularization. So it did not show differences. Statistically, there was no difference between, if you counted death, stroke, myocardial infarction, there's no repeated revascularization here included. But again, same trend is shown. There's a crossing long term. We still am interested to see the 10 years outcome of the Excel study. Again, if you look at this study here, ischemia-driven revascularization, same problem, exists in all the studies. Odds ratio 1.84 is not crossing the unity, so it is in favor of Cabbage. So you do have actually more events and more repeated events or repeated vascularization in the PCI group. This is the most recent one, which is probably going to, Bassem will hate me for this, but this is, I just got, I think recently, is the FAME3 trials. Apparently, maybe they can comment to me because I'm not the expert in this field. Doing PCI guided by FFR is much better than doing PCI without FFR guidance, which is a flow reserved flow. So they are done the study to compare PCI guided by FFR, which is called FAME3, versus Cabbage. And they looked at the outcome. Unfortunately, Cabbage won again at 1 year. Believe it or not, at 1 year. We haven't seen the long-term outcome yet. So it's not inferior. The non-inferiority of FFR-guided PCI versus Cabbage has not proven. So Cabbage still good. So even Cabbage compared to the FFR-guided, to me, it looks like this is a very strong, powerful message that in complex 3-vessel diabetic left main, I think Cabbage consistently across all the studies show that it is superior strategy for when it comes to revascularization. They all three vessel disease. The mean syntax score was 26. They're not only including the high syntax score. There were left main disease were excluded. 24%, sorry, the 22% have complete CTOs. 68% has bifurcation disease. Mean age was 65, a bit younger. And yeah, I think I like the European guidelines better than the SDS or the Americans. I think they have it very nicely displayed, and I do disagree with some of the update in the, I think when they are labeling three vessel disease as a class 2B in the American ones. But I think we all just, from what we've seen in the literature I just reviewed, left main, proximal stenosis of the LAD, diabetic, I think they all class 1, left main, class 1, level of evidence A, three vessel disease with diabetes or without diabetes, still class 1, three vessel disease with diabetes, class 1. So I think it is in the guidelines too. These are the main, I think, what we see in practice. In STEMI, I think we all know that revascularization, especially from the shock trial, if you can do it with either PCI or Cabbage, it's actually class 1. So you should offer patient. These are the things that we probably, when it comes to talking about evidence, class 1, class 2, I think most of you know, and I just, if somebody wants to see it, I can explain it. I think Muhammad al-Harari has explained this in the previous lecture with the heart failure. So basically class 1, it's the strongest. Class 2A, it's a moderate. Class 3, you don't do it because it's harmful. Level of evidence A is from high, it's a high quality coming from more than one randomized controlled trial or meta-analysis of high quality. The level B is probably have one study from randomized controlled trial. Level C is non-randomized. I just want a word of caution here. If you look at the studies, even the ones that we are comparing and we see the Cabbage is superior, the note that you have to make is most of these studies are younger patients. Most of these patients are well-preserved LV function. Look at the ejection fraction. Imagine including, I mean, these are most of the patients seen in those studies, they're not 100% reflective to what we see in practice. Like the patient you see in practice, 78, 82, 67, 79. So I think, and the EF, I mean, to be consistently, your EF is 65 or 65 and above. I think it's not, so you have to be very careful. And when you're trying to extrapolate the study results into your practice, if you have that 82 years old with EF of 19%, that study or that vessel was 1.25, not like a 3-4 millimeter vessel. So I think you have to be very careful. The patients selected for studies are usually different. I'm not going to spend much time on this. I think quickly, just on the minimum invasive Cabbage, it's something I do here, and I've been doing it for 11 years. I've had over 110 cases. I think this is probably the future for coronary surgery. Why? Because surgeon, I think they need to minimize or eliminate the stenotomy to decrease the invasiveness of Cabbage, to preserve the complete revascularization if they can, and try to apply it for multi-vessel disease, and able to learn and perform routinely. And this will result in decrease of cost of Cabbage without the need of complex infrastructure, okay? You don't need a robot or anything to do it. So it is usually an off-pump procedure done where the Lima takedown performed under direct vision through a left mini thoracotomy. I usually make about 5 to 7 centimeter. I did one yesterday on an 88 years old and was extubated in the operating room. And sometimes in certain cases, you could do pump assisted. And especially in some centers who actually do more, I usually do 1 or 2, but some centers, they actually even bypass the circ and the PDA. That's how your approach and the tools you need from Medtronic in terms of what we call a stabilizer while you're operating. So you stabilize the target and the positioner to help you to position the heart. And these are usually your incisions. This is my patient yesterday who's 88 with the PCI to the LAD with a class 2 angina, healthy otherwise, had a stent to the prox LAD in August 2020, came in with this recurrent of his symptoms, and he had that ostial 70% LAD. The cardiologist called me, can you see him, consider him for mini? because he's symptomatic and we don't have much of in the way of landing zone. And you can really probably appreciate. It's a very nice distal target. You can see the shadow stent is actually nice and patent, but there is the disease here developed prior to the stent. There. Okay, take home message. Cabbage is here to stay. We need to perfect it well and do it well. Cabbage should be the first option for treating coronary disease in patients with diabetes, high syntax score, 3-vessel disease, and left main. Lima is the golden graft. It's what kept us in business. Otherwise, we'll be selling some other stuff in maybe grocery store or somewhere. The second best conduit, just think about radial and Lima. But unfortunately, there's low adoption rate. Heart team approach is here in the guidelines for complex diseases and cases and should be used routinely. Minimum invasive surgery and hybrid revascularization is the future. I didn't speak a lot about hybrid, but hybrid we mean here, we do minimum invasive Cabbage, Lima to the LAD, and I send the patient to stent the RCA or the circ. I've done probably 4 or 6 patients, very good outcome. Patient is happy. You've had patient coming to you with 60% RCA or 60% circ, and you had a tight LAD. You do the LAD, patient improve. You leave it up to the surgeon or the physician whether to PCI the other targets, because you don't want to be cracking chest to do a vein graft to a 60 or 50% RCA. I think this is being utilized in a lot of other centers. And well-conducted RCT is needed to test the rule of modern viability test in relation to prognosis and functional recovery. Sorry, Bassem.
نوري عادل، المحاضرة شيقة صراحة وكانت اكستنسيف. أنا عندي سؤال نبدأ به، يعني في أسئلة هلبة في الجروب وهنحول نحول إلى الميوت، لكن سؤالي كنت تكلمت أنت على الأوف بامب، نسألك سؤال غبي شوية. شنو هو الأوف بامب؟ شنو تقصد به لما تقول أوف بامب أن بامب؟ اعتبرني أنا كيف متخرج من كلية الطب وما نعرفش معنى الكلمات هذا، شنو تقصد بهم؟
الاوف بامب يعني انت ما بتشتغل عاده روتينلي you have to connect the patient to the heart lung machine and you arrest the heart. لا يعني you have to work on a very flaccid arrested heart. Off pump means that you actually constructing the anastomosis. You're doing the bypass while the heart is beating. You're only fixing the area where you're anastomosing. Like for example, if you're doing the LAD, you just have special tools. The heart is beating. You open the chest routinely. You just have those devices, and you stabilize the target. And you've had probably a 1 or 2 millimeter range of motion. You open the vessel. You shunt it. You put a shunt, and you construct anastomosis the way you do normally. So the heart around you moves. The RV, the RA, the patient's sinus rhythm pressure is monitored. So basically, you just move from one target to the other, and you do it routinely. So you can do this. I do it both minimum invasive with Lima to the LAD, and I do it even for if I need Cabbage 3 or 4 in some people. But the concept is the heart is beating. All you need to do is to stabilize the target with special tools, and to minimize any chance of arrhythmias or ischemia while we're doing it. We usually employ the use of small shunts in the vessels across the anastomosis. As soon as I'm done with the anastomosis, I pull the shunt out, and that will ensure that I don't get any sort of arrhythmias or any ischemia I don't develop. Although the anastomosis 5-10 minutes is not going to take much, but again, sometimes you run into trouble with a bit of a difficult anastomosis. You don't want to, one of the reasons is when you talk about off pump, you always talk to your patient about the risk of conversion, because you could start off and you end up being on. That is not a big deal if the patient has no contraindication to be on pump. Like if somebody is a calcified aorta and you crash, become unstable, then you don't have lots of room. So sometimes it's you do everything you can to minimize the.
علاش مشكله الكالسيفايد ايورتا؟ علاش هذا يسبب لك مشكله في السelection نتاع البامب؟ You did mention يعني الكالسيفايد ايورتا you'd prefer off pump. ممكن توضح
Because I think when we do surgeries, the aorta, distal aorta is placed for placing our cannulas, and also the aorta has to be clamped. So if there is any hint of calcium, whether it's on angiogram or a CT, or when you open, you feel it with your finger. You feel it. And also lately we've been using epi-aortic scan to rule out any plaque in the aorta. So if there is any hint that there is a plaque, because the number one cause of stroke post-surgery is calcified aorta. So if you have a calcified aorta, you don't want to cannulate it, you don't want to manipulate it, you don't want to, because you're going to cannulate it for establishing the heart-lung machine. You're going to cross-clamp it, and you're going to poke it for constructing the proximals. So you don't want to do any of these. So in my off-pump cases, I've had other alternative ways of doing it. For example, I can tell you the cases I've done recently. I could do Lima-Rima. I do Lima-Rima routinely, and I could do Lima, and I could Rima, and use the Rima as an inflow to do, for example, sometimes I do Rima and attach a vein graft to the end of the Rima, and then I do off-pump side to side anastomosis to the PDA, and then end of the piece of vein to the circ, and I do complete revascularization without even coming close to the aorta. Lima to the LAD done, and Rima as an inflow to the PDA, and extension with the venous graft to the circ. And this could be done safely, completely off pump. So again, it's the aim is whenever you see calcified aorta, one caution, whenever you see a calcified aorta, you always have to look for left subclavian stenosis, because the last thing you want to do, you commit yourself to do surgery, and you go in and you harvest the mammary and there's no flow. And I think I've had 2 cases like this, and the CT was done and shown that the Rima was okay. So actually I harvested the Rima, I used the Rima as my inflow, and I used the vein of the proximal Rima to the LAD, and the same thing. So I did Cabbage 3, complete revascularization in 86 years old. Everything is off the Rima as an inflow. Did not touch the Lima, did not touch the aortic ascending aorta. So calcified aorta is a problem for stroke.
Sounds good. دكتور رضا انت معنا في الاكسبرت بانل. موجه لك السؤال الثاني. شنو عادل تكلم على الهارد تيم ابروتش، يعني الهارد تيم ابروتش ان السيرجن انترفنشنال والكارديولوجيست discuss the case to decide how to proceed. شنو خبرتك انت في البراكتس بتاعك سو فار؟ هل يعني انت كم ليك سنه تخدم، هل لاحظت ان في ادابشن مور للهارد تيم ابروتش؟ هل الشيء هذا يستخدم في ليبيا وعلى الاقل في المحيط بتاعك؟ ونتمنى نسمع منك يعني تعليق خارج.
I think team approach, السلام عليكم أولاً. Team approach is really now mandatory for all practicing teams of good quality cardiac services, whether cardiology or cardiac surgery. And as Adel pointed out, it's a class 1 indication. What's happening in Libya is something else we cannot really discuss very much, because in the government setup, there's hardly any open heart strategy going. In Benghazi, for sure, last year, we didn't do any more than 40 cases, maybe 50 cases maximum. However, on the private side, I think the situation is different, as you know, because the patient either will be coming to you from your local cardiologist in the private hospital, in which case you probably have discussed the case with you, who can count that as a team approach or a team discussion. Although it's not really classic. I think what we had in Saudi Arabia, we had a daily meeting every morning for cardiologists and cardiac surgeon joint meeting to discuss everything, including admissions, the status of patients in CCU and ICU. And then we'll have a specific time. If we have time that morning, we'll discuss patients who had cath yesterday, who need to be referred for surgery today, and we'll take the team's opinion. The other thing which Adel did not touch on was something called Syntax 2 score, which is a very good score that allows you to input the data about your patient. And the score will come out and tell you, well, this patient will do better with surgery, and that patient will do better with PCI. I think that will be a very good tool to be applied by the cardiac teams, wherever the heart teams, wherever they are worldwide. I think that'll be a super tool, and I'm surprised it has not been applied yet in Canada. This is the answer to this question, but I have some other comments I could do whenever if the time allows later. Thank you.
شكرا بارك الله فيك الدكتور إدريس. حتى أنت معنا على الإكسبرت بانل.
في سؤال باسم من محمد الحراري. على الفلو and الليما الكيس اللي قال لي Timmy 3 flow and LAD with patent stent. Does she have objective evidence of ischemia? Did you have that question?
ايه السؤال الاخير اللي كانت على الكيس اللي درته شوالتها 88 يورو اللي درته امس الليما 2 LED على proximal LED lesion يعني it looked like a patent stent يعني في الانجيوجرام هل هذا عنده evidence of ischemia and the concern is if you put a graft on that with proximal LED lesion is not flow limiting is it worth that procedure فهذا تقريبا السؤال على that case أنا ما شاء الله big hands up so عندك 30 seconds to answer.
I think I discussed this case with the cardiologist. They have, at least they're calling it 70-80% osteal because I think it depends on the view. I didn't show the good images because it's kind of covered, but it is a very significant disease. And the guy is 88, but you ask him, he's symptomatic. So I think in the presence of symptoms, I think it's proven to me, the guy was okay after PCI. And I think he developed over 2 years. So the quantification was about 70-80% osteal LAD. Presence of this plus the symptoms, I think both of them, I wouldn't be worried too much about the Lima graft go down.
Fair enough. الدكتور حاتم رافع يدك انا مش بالرافع انت من الاكسبرت بانل اي شيء عندك سؤال ولا everyone can unmute themselves توا يعني في اللحظة هذه. I've opened that up. استغفر الله. No, now you can unmute yourself.
Okay. مهيار حمداني كيف حالك؟
Great. Yeah.
Okay, go ahead.
Thank you very much. Can I talk? Yeah.
Yes.
Yeah. Assalamu alaikum. As usual, Adel, mashallah, very well covered. I just want to ask something about the European guidelines for the cabbage. I understand because I know David Tiger very well. The only thing that we win with no doubt in cabbage is when the patient is diabetic, no matter what you do. I don't know if you have discussed that before because I'm halfway through the lecture. The syntax score, if it's regardless diabetic or non-diabetic, always diabetes when that's the biggest negotiation with the cardiologist. The only thing that I want to discuss is regarding the Excel and Noble. The Excel has been disapproved by the panels in the European in IACS basically because there's controversy. There's controversy with the how they define the myocardial infarction. Basically, it has disapproved and replaced by the Noble. The Noble that shows that the Cabbage is more effective than PCI in terms of risk of death and the revascularization and both arms. I just want to add this to the regarding the Excel trial because I know that Adel, you mentioned it, but I just want to comment that has been disapproved by the European Society. In regard to diabetes, there's, as you mentioned, Adel, you mentioned about the Freedom trial. That concludes diabetes surgery is much better than BCI. However, there's a cardia trial. I don't know if you went through it, which is again compare the diabetic patient regarding non-diabetic patient, where the 5 years outcome is still favored Cabbage. However, they did mention that it's not off the top of my head, but they said the PCI is not inferior. So I don't know if from the cardiology panels or cardiology colleague, if they can comment us more on the cardia trial, because as far as I know, the 5 years survival is, the outcome of it for after 5 years shows benefit of Cabbage over the PCI in still diabetic patient. Yeah.
مهيار حمداني.
Oh, sorry. One more thing. Just I want to remember because you did mention the radial artery. The radial artery is there's a RAPCO trial. There's a RAPCO trial that was being concluded in 2020. I think you can find this in the circulation. Yeah. They showed that the radial artery is much better than the free Lima. So I usually if I need to do tutatria, I do Lima to LAD and then I go to the next one, which is the radial artery, providing that the The stenosis, like mentioned, Adel, it's more than the 70% in the left and more than 90% in the right. So there is benefit from the RAPCO trial that there is evidence that radial artery is superior to Lima, and obviously more than the vein.
I agree.
So I missed some of the comments, so that's why I was like, probably you have said it already.
Yeah, I did mention Hatem. There was I didn't want to, and it was on the table. I don't know if you noticed the slide, but I don't want to dig into details because I'm trying to cover as many topics. I agree.
Mm-hmm.
I think it seems to be radial is becoming the second best choice after Lima. There has been a lot of meta-analysis, a lot of observational studies. I think the Sunnybrook and Basim knows the Steve Freem trial, and they were the first who looked at the patency and looked at the clinical outcomes. I think what we learned from most of the randomized controlled trials in radial, you have to be very careful as to where to put it and what type of targets. And we all agree it has to be tight stenosis. That is a must.
Yeah.
And I agree with you. And even with the vein, when it comes to vein, there is a lot of Asian and a lot of Chinese and Japanese. I was in the World Congress of Coronary Surgeries in New York before the pandemic. And the whole session was about a no-touch vein harvesting. They actually harvest the vein as a big pedicle with the nerve, with the saphenous, with the fat, everything. It's a very actually ugly disfiguring. But I'll tell you, they will promise you patency rate of 94% at 5 years. I think part of the reason the radial failed is because it is skeletonized initially. Same thing, vein, if you guys come to the OR and see how abusive our assistant and our system, or even myself when I take it, I used to take the vein when I was in training. We're pulling, we're doing, the amount of respect we have to the Lima is not the same as, and it's not like to discount anybody else who's working in the vein harvesting. I really appreciate all the work that everybody's doing, but it's not their fault, it's by default. The amount of pressure we're pressurizing those veins, the amount of manipulation, mobilizing it from the vein, the nerve, and trying to preserve the nerve, there's a lot of trauma. The memory, you try to touch that intima, you get slapped in the OR. It's a very, very, very delicate structure, but the vein, everybody get in the cold solution, it gets spasmy, get pressurized, it just doesn't, but people tell you, if you harvest it as a pedicle with surrounding fat, it stays open because no touch technique.
Yeah.
دكتور إدريس نبي نوجه لك سؤال لو معنا لا يفتح المايك وقدم نفسك لو إذا كان ممكن. أهلا وسهلا بك.
مرحبا، السلام عليكم. Can you hear me?
إيه نسمع فيك كويس دكتور.
Okay, مساء الخير جميعا. دكتور عادل, thank you very much for the nice presentation. أنا دكتور إدريس علي, بخدم في ألمانيا في University Hospital of Saarland cardiac surgeon. أنا كملت ريزيدنسي قبل 4 شهور يعني just I'm new.
ما شاء الله الله دم جديد ما شاء الله اللي انضم الوقت. إدريس بالنسبة للموضوع الفايابيليتي يعني عادل brought it up in that first case وبصراحة I was a bit surprised in that our team was reluctant and someone who's relatively young with reasonably distal good graft targets يعني اتوقع يعني احنا في الهارد تيم بتاعنا احنا في الحالات هذه we just say go for surgery نقول برا السيرجري وكان في extremely high risk we're looking for a way out maybe يعني لكن I would like to hear your experience يعني في اليوز بتاع الفايابيليتي.
اوكي طبعا لازم الجول بتاع any revascularization سواء PCI او Cabbage is complete revascularization should be the first goal. It's very important. حاجة تانية طبعا المايوكارديال viability test طبعا أنا ما درتش يعني أنا مش من الناس اللي بيركزوا على الشيء هذا. ممكن الإيكوكارديوغرافيك finding if there is regional wall motion problems في حالة هذه ممكن أني نفكر. حاجة تانية لازم أني نشوف الاريا الفيزل الديزيز فيزل سبلاين لو الاريا صغيرة و not significant في حالة هذه لازم أني نكون very يعني I have to be a very caution يعني. بس لو الاريا supplying disease visit is very big I try to do bypass on this disease vessels. I think it's very important.
I think, Bassem, I can comment on this case when we discuss it. I think what's important is the way patient present. He presented multiple times to a walk-in clinic with symptoms of cough and shortness of breath. He never actually had chest pain. So people was treating him for COVID and bronchodilators, buffers, blah, 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 blah. So I think if patient comes to you, I think it's very alarming if somebody comes with EF of less than 20% or 20%, no angina. I think you have to question, you have to prove that that myocardium is viable. But I think I have a different strategy. Whenever I see people like this, I always look at the echo. I think the echo tells you. If the apical anterior wall is thinned out, dyskinetic, you can tell. If you look at this echo carefully, maybe I can leave the slide and you can look at it. It's actually the apex still thick. It still has some thickness. If it is thinned out or completely dyskinetic, aneurysmal, then forget it. This is you guarantee. You open this guy, you're not going to derive any much benefit unless you're doing a door procedure or some sort of other reason for it. But the guy does not have significant MR. He is having shortness of breath. He actually improved with some medical therapy, but he still have an LED diagonal that we see on right shot. He still have two circs that's occluded. He's 64. So I think to me, having the additional viability assessment was actually voted by everybody, to be honest, Bassem, because with his presentation, people did not fail to jump on. Remember, Bassem, there's a huge number of general cardiologists attending this, and they're fighting with the intervention. If we say surgery or PCI, a lot of them were saying, why? Prove it to me. So that there is actually pressure.
Yeah, but that's interesting.
Can I?
Yeah, I would. في حد تاني بيتكلم من ال.
Yeah. Can I add something, Bassem and Adel? There's a good meta-analysis. Yusuf meta-analysis. He had multi-combined trials. It's not on top of my head because, like I said, I was driving and I'm using my mobile at the moment. So I remember in Yusuf meta-analysis, they showed they compared many the surgical arm bit and significant and showed survival benefit for those who have cerebral disease and abnormal LV function and positive exercise test. So and when they compare Cabbage versus medical versus PCI, Cabbage is win here. So I will read about the meta-analysis, use of meta-analysis. I'll probably get you feedback with the outcome. But it is surgery definitely wins when the low LV function with positive exercise test.
Yeah, well, we know the Stitch trial, Hatem. Stitch trial has proven like EF less than 35% if you do, but follow them up to 10 years. There was a clear difference and survival advantage of Cabbage over medical therapy. That's no doubt. That's proven by Stitch trial. But adding any surgical restoration therapy to addition did not make any difference if you're doing any aneurysmal treatment or anything. But having the surgery, and I think I highlighted that having the surgery is probably protecting people on the long term from dying, mainly preventing the arrhythmia deaths, maybe not from pump failure. Because I think if you have a really bad LV and you revascularize, you could potentially derive revascularization benefit at long term. I think if they haven't followed Stitch group up to 10 years, they might not have seen this because early on wasn't very clear. So a Stitch trial have shown that Hatem very clear that Cabbage is superior in LV dysfunction.
Yeah. Yeah, I think the Stitch 2 that's compared also the reconstruction of the LV left ventricle, which did not show any benefit, just added the risk of the LV reconstruction as well.
Yeah, adding any restoration therapy, did not influence that.
دكتور مهيار معنا بكري كان بيعلق تقريبا، كان قاعد موجود. تفضل. باين انه طلع. أسامة القصبي رافع يدك. تفضل أسامة، عندك أي سؤال أو تعليق أو؟
السلام عليكم.
وعليكم السلام ورحمة الله.
What an amazing talk, Adel. Thank you very much for enlightening me, at least. But as you know, Adel, you're a cardiac surgeon. You hardly see the patient before the surgery, and you probably never see the patient after the surgery. We end up dealing with the mess. So I just have 3 practical questions for the majority. I think the majority of the audience is probably they're not cardiac surgeons, so probably cardiologists who deal with patients. in the office and so on. So I have 3 questions, but I was told in the past to ask 1 question at a time. So that's what I'll do. I'll ask a question just before surgery, a question during and just after surgery, and a question as an outpatient. The first question is, which patients with multi-vessel disease are safe to discharge from the hospital and have Cabbage as an outpatient? And is there any score that you use or any criteria that you use to say, you know what, this patient is stable to go home, I'll do it as an outpatient?
أسامة السؤال متاعك ممتاز جدا باش نشاركوا الأكسبرت بانل بعد ما يرد عادل نسأل الدكتور رضا شنو تعليقه على الشيء هذا.
آسف, sorry.
Okay, shall we take the question now or wait for the other question?
لا خذ السؤال بسؤال. I think that works better than.
Well, I think the reason most of the patients often will go home and come back for surgery anyway, but the patient who will need surgery on the same admission during referral post-cath are patients who have unstable angina, for example, or have severe symptoms. And these people, if you have to keep them, you probably have to keep them for a longish time because you have to stop aspirin and or Plavix. Remember, they probably had an angiogram yesterday, and they had a very good dose of Plavix and anti-platelet agents. So unless the patient have severe symptoms or have severe signs of ischemia, we probably will send them home, bring them back for a pre-op assessment. I think we see our patients before surgery. Dr. Gosby, we didn't just see them in the operating theater. We bring them back for assessment in outpatients and request if any additional investigations needed, including ultrasound carotids and renal function evaluation and so on. And then if we have a slot for immediately after a stop Plavix, within 7 days, we will take them to the OR. But unless there's acute symptoms and unless there's significant ECG changes, of course, if they have cardiac enzyme, you probably have to ignore. If they have raised cardiac enzyme, you may have to abandon the concept of precaution with antiplatelet stoppage. You may have to go and operate on them as soon as feasibly when in the next available OR slot. Thank you.
Can I say something here? I think I do agree with a lot of what Dr. Laoukli said, and I think when it comes to patient, like we see this every day. I think the patient symptom profile is important. Looking at the angiogram, you can tell there is, and even the cardiologist, Bassem, can tell you. We can tell you this is a fresh clot, or this is depend on the lesion. If it is 70% left main or 70% prox LAD, 3-vessel disease, there are a lot of 3-vessel disease, but patient class 1, it was just a positive nuclear scan that shows and led to this, or a lot of these days cardiac CTs, calcium score, and then 3-vessel disease. Really, Cabbage? But I have no symptoms. I was shoveling snow yesterday. I will not keep this patient home. I will not keep this patient in hospital. I would not. But if I see a nasty looking distal left main, 95%, at 60 years old, I would keep him. So I think the anatomy is important. Patient factor is important. I think it's usually there's an agreement between the referring cardiologist. When they do CAT, they would text you, can you come and see this guy? I am making a bed for him. Versus the other guy, oh, no, don't worry about him, see him tomorrow. Call him next week. So there's that feeling between the combination of symptom profile and anatomic. I think most ugly left mains, we tend to keep. 60-70% left main, a guy's class 1 symptoms, he's been living with this for 6 months to a year. The problem, especially these days with system like Canada, you cannot keep everybody. We're not in a private practice, right? Technically, you cannot do it. You cannot keep everybody. But what I do, Osama, just to assure you, I do see patients, as Reda said, before and after, and I have a secretary who calls and label. So if I say somebody in the HIU, heart investigation unit, after a CAT, they said left main, I would write on his chart and put 3 X's, urgent pre-op consult, surgery within 1 or 2 weeks. Versus the other guy who had aortic stenosis, valve area 0.9, mean of 38, mini AVR, he needs a cardiac CT, will invite him again to go over the plan to find out which way he needs a CAT. So that's a different story. He is symptomatic, class 1 heart failure or shortness of breath. But I think also the way we label and we prioritize patients.
السؤال الثاني أسامة.
Barakallah, thank you guys very much. Just a question, just a comment on the first question. So just the point, there's no score that you can use that you know of that can help you decide whether to discharge the patient or not. It's a combination of the presentation and the anatomy of the patient and ECG findings, just so that we're clear.
Can I comment on from UK point of view? We don't keep the patient too long as well. The way when we do in-house, we call it in-house cabbage or in-house operation, is for those who are only considered to be emergency, or those who had failed PCI, or those are unsuitable for PCI anyway. And there's ongoing ischemia, or patient who got devolved cardiogenic shock or required an intraballoon pump. But there's no score per se to say whether this patient can go home or not. It depends on the usually our cardiologist is the one really decided whether, he go for surgery, but whether he still be as inpatient or not. So we try to discharge the patient as possible when they are stable, as Adel said. So there's no specific score to that.
Thank you very much. Question 2 has an A and a B section. Question 2A, do the surgeons now always remove the left atrial appendage during open heart surgery? And part B, how do you manage post-op, post-Cabbage atrial fibrillation?
Can I answer this question? Since this trial, we have actually one of my colleagues published over a 3,000 patient study, but that's you're talking about AFib patient or anybody who's undergoing sternotomy, Osama. Can you clarify the question?
Anybody who's going sternotomy.
No, I think anybody, I would not take it. But clearly, if there is somebody who has AFib, I think in our centers, there's that tendency now. Anybody who has AFib, you either two options. At least you remove the appendage, or you do concomitant maze procedure, especially if it is not persistent, huge atrium, blah, blah, blah. But to remove the appendage in everybody who has no AFib, no. It's a short answer, no. But there is a proven evidence that the removal of appendage in patient with AFib reduces the risk of stroke.
Yeah, and I agree. Oh, sorry. I just want to comment as well. I agree with Adel. And the other thing is we don't do concomitant maze with Cabbage. Usually we do concomitant maze if we need to do valve as well, so you can open the atrium. But for just isolated Cabbage, we just do the excision of the left atrial appendage to prevent thrombus.
And if you do it for the maze, I think it's the new evidence is you have to do bilateral, right and left. The problem is, I think we're lacking is the equipment. We need to have the cryoprobe. That's a different story. The other question you have is how to manage post-op AFib. Any AFib that's persistent, like say it's not a short run, but if it is more than 24 hours, we usually anticoagulate. And luckily in our center, because our patient post-op get run or looked after by peri-op service, mainly cardiologists and medicine. And we also have, which is, I think I want to bring it up so that people could actually probably start using it more, is we have people who develop AFib post-op. They go follow one of our colleague, he's actually interested to follow all the patients who develop AFib anticoagulated on Amiodarone to go, because usually put them on Amiodarone for 6 weeks. So they get followed with Dr. Bill McIntyre, who is seeing them, does Holter monitor for 2 weeks. He decides when they come off warfarin or not. So there is a track of patients who develop AFib. They go into same thing, low ejection fraction. There's a low ejection fraction clinic, heart failure clinic. So I think this is a good area that probably will help to improve outcome in patient with certain outcome like this.
Okay. And sorry, I have to comment. I think the main problem with the left atrial appendage resection is the probability of post-operative bleeding. In our center, we see about 1 to 2% of patients after left atrial appendage resection, they need re-thoracotomy or re-operation. I think there is no need to do for every Cabbage patient left atrial appendage resection. If the patient has atrial fibrillation, sure, but otherwise, I think no, in my opinion.
But Dr. Idris, I think with the new innovation with the use of the AtriCure clip, you can actually clip it. You don't have to resect it.
Yeah, you don't have to resect it. Yeah.
I think it's a bit of a cost issue. The other thing is probably very important when you do atria appendage removal, and those who are not experienced, the circ is sitting next to you. So you could have, we have actually a case where the circ was ligated and you end up with a massive infarct. And patient
absolutely agree. Yeah.
Patient died.
Should have had
Right.
PCI.
So, unless you're bypassing the circ already. Well, PCI, I'm not sure your wires will go through those ligated.
No, before the ligation, before the surgery. But anyway. سؤالك الثالث وجه للدكتور إدريس.
معلش السؤال الثاني, just to be a little bit specific, so we can all benefit and our junior colleagues can benefit. Which anticoagulation to use and the duration of anticoagulation? So I know, Adel, like I said, you turf the patient, like you said, to the AFib clinic, which is fine. But in terms of duration of anticoagulation, from what I know, is 4 weeks of oral anticoagulation and then reassess. And the oral anticoagulant of choice, from what I understand, is still warfarin, not necessarily one of the new oral anticoagulants. That's the duration and the choice.
I think for you're talking still on AFib, right?
خلي لي الدكتور إدريس هو السؤال.
لو انا فهمت سؤال كويس، معناه انتي كواجوليشن لو المريض بعد الكابج عنده اتريال فيبريليشن.
ايوه.
Am I right?
Yes.
اوكي هذا يعتمد على المريض هل مثلا pre-operatively he is already on paroxysmal atrial fibrillation or not.
No, new AFib. Sorry, new atrial fibrillation.
No, in this case, just use antithrombotic therapy, for example, subcutaneous low molecular weight heparin during hospital stay. And at discharge, if the patient has any atrial fibrillation, in this case, I don't need any anticoagulation. But the patient, if he has atrial fibrillation post-operatively, I start amiodarone for 2 or 3 days. If the patient still in atrial fibrillation, in this case, I do electric cardioversion, and if he's stable, he don't need any anticoagulation. This is our protocol in our center.
Bassem, I think you need a cardiologist to answer this question. Can I make a comment?
تفضل يا تفضل.
طب أنا طبعا agree مع دكتور إدريس what Adel said. Like I just want to let you know guys, في statement بالAmerican Association of Thoracic Surgery في 2014 and was dedicated for post-op AFib. It's not a guidelines. It's like consensus statement. Very, very good statement. The main highlight, any AFib is AFib, whether it's 10 seconds, 1 day or 2, any post-op AFib is AFib. You calculate the patient shared vascular score. If it's 2 or more, you anticoagulate. And amiodarone, like what Adel said, you keep them on. Like amiodarone is a class 2A indication, even to prevent the AFib, regardless if it's valve surgery or cabbage. You bring them back, like what Dr. Idris says, in 4 to 6 weeks. If they still in AFib, this is you consider cardioversion, bringing back a normal rhythm, and actually the thought process, maybe this is not just post-op AFib. Maybe this patient already had a substrate for AFib, and the surgery was just the trigger to the AFib. If in 4 to 6 weeks, if the patient did not have any recurrence of AFib, and the monitor, we do like a 1 day, 1 week or 2 week or 1 month, whatever, the practice is not clear, it didn't show any AFib, it's safe to stop the anticoagulation. However, there's a large database from Emory Clinic, around 10,000 patients who had a post-op AFib 10 years down the road. Those patients, they have high risk of stroke. So keep that in mind, like don't down-regulate post-op AFib and treat it as a chronic disease. But this is like that statement, the 2014 statement. I guys encourage you to review it. I may send it in the chat box here to review it, but it's kind of, I think, aligned with what Dr. Idris and Adel said. Thank you.
Can I comment? I think I agree with Ayman for a lot what he said. I think we are, our cutoff is minimum of 3 months. And I think we are lucky we have arrhythmia and a thrombo service following our patient who developed AFib. And I agree with you, any AFib is significant. So at 3 months, all of them go on warfarin. And recently, one of our cardiologists wanted to do a study to compare use of warfarin versus NOACs in the immediate post-operative setting. We all get anxious when we use NOACs in the post-immediate or post-operative setting because of the risk of bleeding, because they act right away. Within the fresh surgery, you don't want to, heads roll to right away. So I think now there's an ongoing study, and I think maybe Osama, I've mentioned that to you before. They're actually recruiting, and they actually randomizing patient whether they go on NOAC day 2 or day 3 versus warfarin to manage their AFib, and then they can follow them whether they can discontinue based on the thromboservice decision. The other thing I would highlight the important message that Ayman said. I just read a recent paper. People who develop post-op AFib, lifelong, they have 9-fold increase risk of becoming permanently AFib or develop AFib, and their risk of stroke and dying compared to the average population is actually higher. So do everything is actually, I was talking to my colleague to try to implement the policy of amiodarone or any other maneuver. There is evidence amiodarone prevent AFib. There's evidence colchicine prevent AFib. There is also evidence that the use of atrial pacing wires also prevent AFib. Again, I think you just logistically starting AFib, amiodarone prevention before, especially in the same day admit, and the safety. I think the safety profile has been proven, but again, do everything you can do to prevent AFib from happening in the first place.
عادل معلش بس باش أسامة القصي ما طلعناش سؤال 2C ولا 2D. بالنسبة للانتيكواجوليشن there is no difference in our practice for warfarin ولا NOACs. يعني we do NOACs actually heavily unless patient had mechanical prosthesis. That's a different story. Like one more thing, in general in our practice طبعا I would like to get the surgeon input, Dr. العوكلي و Dr. إدريس و Dr. حاتم. احنا in general we start anticoagulation بالNOACs after the chest tube is out, after the drainage out, the lines out. يعني this is like to avoid the bleeding. This is our practice. يعني we start an anticoagulation with the NOACs after all the tube is out. مش عارف دكتور إدريس وباقي الدكاترة.
How about the pacer wires?
All the wires out.
I personally don't recommend NOAC for, especially for valvular AF. The problem with NOACs, it doesn't have antidote. With the warfarin, if you still can give vitamin K, you still can give FFPs. And early after the operation, the patient is prone to have bleeding. So the recommendation, our local recommendation, which is comply with the European guidelines, there's a I can't remember what grade it is. But within the first 3 months, it's better not to use the NOACs post-operatively, but it's still not class 1 indication. So I'm implemented this. I could use warfarin, which I can reverse easily, but NOACs I can. So until the patient after 3 years, they can. If it persists and become permanent, then you can go on NOAC.
كان عفوا حاتم في European statement ان it's safe to use NOACs for bioprosthetic valve, لكن زي ما قلت انت صح البريفرنس warfarin.
Yeah, preference. It's not especially with the mitral Adel.
غير just to clarify يعني لان في European statement and it's safe use them, لكن بالضبط 3 first month in a high risk of thrombosis they prefer warfarin. شكرا. متأسف عليك.
Thank you very much. Can I just give what my practice is, because there's really no good evidence with everything. But Ayman, as you mentioned, there's really no good evidence to compare warfarin use versus new oral anticoagulant use in this population. So the safest thing to do, the established thing to do, is to start warfarin. But going back immediately post-op, within the first 24 to 48 hours, what I usually do is try to convert the patient to sinus rhythm electrically if I can. If there are still pacer wires, we can do override pacing to try and see if we can convert them back into sinus rhythm. If they don't, then we electrically cardiovert them. Now, going back to what to do before the patient goes to the OR, there are studies of amiodarone as well as beta blockers. And in fact, from what I remember, I don't think there's any significant difference between beta blockers and amiodarone. And to get the benefit of amiodarone, I think the best benefit is to start it, I don't know, maybe a week or 2 before the surgery to get the best effect of preventing atrial fibrillation. And then in terms of anticoagulation immediately after surgery, what I do is actually give intravenous IV heparin, because that way it's shorter acting and it can be to some extent try and reverse it. But not, if you use low molecular weight heparin, it's difficult to reverse. If you use one of the new oral anticoagulants, you can't reverse, unlikely. If you use warfarin, maybe if the INR is high. So that's my take on atrial fibrillation. We'll move on to question 3 and the final one. What antiplatelet therapy should patients be discharged on post-Cabbage?
Who's taking this?
And why and for how long?
يلا حاتم عندك انت هي.
Well, the aspirin is mandatory. This is number one. Clopidogrel is optional. I don't use it, but some people use it for 1 year. But aspirin is mandatory. So, and because the evidence behind that is not clear to me. It's just, you know, but definitely the aspirin. I mean, in regard to Plavix. I don't know, Adel, if you use it or not, but I don't usually use it.
I would, I think for our group, anybody with inpatient who had, like if you're bringing patient who is a non-STEMI coming to inpatient Cabbage, he would get dual antiplatelet for a minimum of 6 months, Plavix or Ticag, plus the aspirin for sure. If I do off pump, I usually ask for aspirin and Plavix for at least 6 months as well, 3 to 6 months. It's all, as you said, the evidence is not very strong. I mean, for off pump, there's that hypercoagulable state. But again, I think more toward, I think there's more evidence toward, especially in the acute setting. And in a lot of our patients, we do a lot of patients with previous stents. But again, depending on how the age of the stent, I think Plavix and aspirin is mostly for people who have a recent acute coronary syndrome.
Yes, yeah.
Cabbage. But a stable patient coming from home with a class 1 angina, usually we just send them on aspirin.
There is a study, I think, that shows that graft patency is far better if you combine both aspirin and Plavix post-operative. But there will be a huge prospective randomized studies, but there is some
sub-analysis.
Evidence.
Yeah,
yes.
Sub-analysis, yeah.
يعني according يعني الاكسبيرينس نتاعي والبراكتس نتاعي لو المريض total arterial revascularization, especially if we use a T graft or Y graft. In this case, we have to use aspirin and Plavix for 6 months, and then only aspirin for a long time. هذا الكومنت. بس المريض لو عنده atrial fibrillation or mechanical valve and he's on warfarin or on NOAC, I think the only aspirin with warfarin or NOAC is enough.
I just want to comment to Sam as the previous, I don't know, questions 2D or 2C. Amiodarone loading pre-op, you need 3 to 4 gram load. So you don't need 2 weeks. I think if you do 400 TID or 400 BID, in addition to beta blocker. So I think your patient, to have the best optimal time for, or a chance of not getting into AFib, you need to be on amio, beta blocker, statins. These are the 3 agents that has been proven that they reduce AFib. So you don't compare beta blocker or amiodarone. You have to be on both. The problem is how you then identify patient. Like a lot of my patients come to the OR with heart rate of 42, 48, well beta block, nicely dried up by the cardiologist. And the CVB is 2. And I think if I give them amiodarone, you may run into trouble. The other thing is you have to be careful, is you have to look at your patient and assess him and read the ECG. I've had quite a few patients come into the OR, same they admit they have a left bundle branch block. I'll tell you, the minute you float the swan, you're having asystole and you're doing CPR on table. Imagine you give those patients another rate limiting agent. So you have to be very careful when it comes to selecting patient who would benefit from prophylactic amiodarone. You make sure you have your eyes on the ECG. You make sure they're not like somebody who's even without beta blockers, heart rate is 50. You'll give them a touch of beta blocker, amiodarone, good luck. You will come with a heart rate of 28 and you will have a syncopal episode. So again, you just have to...
Do you still use Swan? Do you still use Swan GANs in every patient?
Not everyone. Not everyone.
All right. And how about balloon pump? They're out of fashion.
Now we do echo. Now we do echo for everybody. We replace the Swan with echo everybody.
How about IABP post-op with low cardiac outputs?
No.
I know in Germany
balloon pump. Balloon pump. We usually the cardiologist will put it. I think maybe I will put 1 balloon pump a year when we come off. But now we've had I think the use of balloon pump has gone down compared to when I first in training. I think even if you have a low ejection fraction, I mean, I would change my maneuver. I would do off pump. I think you usually need epine or epimerinone. I think the inotropes are good. But again, we still, a balloon pump is an option. ECMO is the next if the patient is younger than 65. But yeah.
دكتور عبد الغني جاي مدك انت ليك فتره سامحنا لكن اسامه عنده اسئله هلبة شو بدي له. تفضل اسال سؤالك والدكتور رضا وجه الدكتور رضا. تفضل.
اوكي السلام عليكم. تسمع فيا كويس؟
اسمع فيك كويس.
اهلا بكم. ما شاء الله discussion very nice and عادل ما شاء الله well done. Adel always in favor of Cabbage, obviously. Like ما تنساش ال PCI Adel, PCI is very effective for selected patients and Cabbage effective for selected patients. So we always work as a team just to remind our colleagues and juniors and non-surgical team and non-interventional team that we do really consider the guideline direct medical therapy is the mainstay for those patients. Whether to go to BCI or to Cabbage, we should always focus on preparing them before and after. So make sure that that's always our consideration. And as you guys mentioned, the teamwork. Our aim is to get our patients better and better soon, get them out of the hospital in a safe situation, whatever takes PCI or Cabbage, and we just need to follow the guidelines. Adel, I have a question about the single and two vessel disease, Cabbage versus PCI. If you can tell us, we don't see any mortality benefit from, or mortality difference, I would say, but if you can just tell us about that. The other question is the early graft failure. I have at least 3 or 4 patients now in CCU, and unfortunately in mine graft failure. And what's the best way to prevent that before and after surgery? Thank you.
السؤال الأول شنو عبد الغني؟ السؤال الأول كان
السؤال الأول single and two vessel BCI versus Cabbage. Is there any mortality benefit difference?
دكتور رضا شنو تعليقك على هالشيء؟
Yeah, understanding that I have, unless it's approximate LAD, single vessel disease, I think medical therapy will give you just as good results as PCI or surgery. But if the patient have to have an intervention, I'd rather that he has a PCI, not surgery, for a single vessel disease. Two vessel disease, again, it depends on the myocardium at risk. If significant myocardium at risk, for sure, yes, he will benefit probably from PCI again before surgery. And we prefer to see patient coming for surgery to have 3 vessel disease with impaired LV function. The other thing that you highlighted too very quickly in your in the introduction, Dr. Abdullani, is the Ischemia Trial. I think it's something that really made me think again about the way we approach patients with ischemic heart disease. I think it's something will be worthwhile considering, probably in a different talk altogether. But thank you very much for the question.
Can I just comment for this question? According to the syntax trial, PCI is better than Cabbage for those who have single or double non-proximal LAD, as Dr. Rida mentioned. Starts to become better with Cabbage as long as you start to have a higher syntax score, and then left makeup and diabetes. These are the ones that the area where we always, as a cardiac surgeons, wins over you cardiologist, basically. But yeah, yeah.
انا يعني تو انترفنشن كارديولوجيست بكري ساكت ف
هذا اقول لك يعني the one I know
for me
استنى فيك انت تتكلم يا باسم من بكري تتكلم شويه.
لا ايه معلش اليوم بخلص سيرجري نتكلم. بالنسبه لي انا في حالات 2 vessel disease نحولهم لسيرجري، في حالات 3 vessel disease والله ما هم شايفينها. 2 vessel disease with complex bifurcation, heavy calcification.
Exactly.
Where I think I cannot get a good result, who has a very good graft target. For me, I think that patient, either medical management or surgery. The vitamin low 3 vessel disease, but they're all type A lesions, very focal. I think the benefits from surgery versus PCI, if there is any, is very small, and it's not worth that. So that's my perspective on that.
I agree with you. Yeah, just to recommend on the syntax. Syntax is the only if you have single proximal LAD is equal to Cabbage, or non-proximal Cabbage is besides better, or if it's none, then yeah, I'll agree with you. It's each case by case.
I think what Bassem alluded to is very important. I think سؤال عبد الغني is very important. When you say single or double vessel disease, I can tell you, is that distal 90% left main single or double vessel disease? Double vessel disease. I would say surgery better. So I think we cannot lump all things together.
Yeah.
I think everything has to be individualized. The other thing is what is actually determining the intervention offered to patient is the service availability. I'll tell you, not to brag about myself, but the minute I start offering the Lima to the LAD Cabbage, I don't think you're going to find in the world centers that have 150 Cabbage 1 Lima to the LAD. If you are offering it, they will start coming to you. But if you're not offering it and it's not available, they will keep treating the next available option. So I think all my patients were failed PCI, total occlusion. They tried to do CTO. They said, no landing zone. So there's a lot of reason. So how can I say this is single vessel disease, isolated LAD? I mean, a lot of them have, maybe 40% have PCI before. But I think it's individualized. And I agree with Bassem. He would probably PCI some 3 vessel disease, and he would be scared from some bifurcation calcified target that he would probably have the surgeon be involved.
مازالوا 10 دقائق بنخشوا على الساعتين. فالسؤال الثاني عبد الغني شنو هو؟ فكرنا فيه.
السؤال الثاني هو اللي graft failure. عندي few patients here admitted with early graft failure prevention approach before and after surgery.
Early graft failure is a problem. يعني تخش في big surgery you come back afterwards with early graft failure. مرات تكون في نفس في same admission، مرات تكون within a year or two. إدريس شن رأيك؟ What maneuvers could you do to try and reduce this risk?
يعني according to my experience graft failure لو during hospital stay يعني most probably due to a technical problem. يعني ممكن preparation لل left internal memory artery زي ما قال دكتور عادل، مرات يكون فيه subclavian stenosis، مرات يكون فيها hematoma في الفيسل، وهذا أدى للgraft failure. والليت عادة other problems, for example competitive flow. يعني in order to avoid these complications you have to be very careful during vessel preparation, and you have to be careful about decision making. يعني معناه انك انت لازم تعرف ان هذا الفيزل مثلا degree of stenosis according لل angiographic findings, according لل FFR studies. يعني you have to be very well prepared to avoid these problems. My mind.
I have a comment on this. I think which is really Abdul Ghani, very important. If you talk to people different places, I would say if you talk to people in Saskatchewan, they do Cabbage 7 and 7, 8 every day. Okay, I think that's a very different. I think for me, I tend to be very conservative. I like to be my principle, 1 graft per territory. For example, if there is somebody with the left main, some of my colleagues will do Lima to the LAD, 2 vein to the diagonal, circ. There will be 4 or 5 grafts to the left system, despite the fact the diagonals are open to the LAD. So my strategy to protect that Lima is I only put 1 graft. If I have an ostial left main, I will put Lima to the LAD and come out. There is no intervening disease in the circ, and it's all wide open. So I think factor to consider, as Adris said, competitive flow. I think most of the time is because you're over-grafting. If you're catting people, you will see some will close by the time you arrive to the ICU because you're bypassing those acute marginal, those second diagonals, you're going to find. And sometimes bypassing them, and they're small vessels, you may actually create some small MIs coming in because your anastomosis wasn't done. So technical factors always an issue. Whether it's anastomosis construction or external compression from your chest tube, your drains, your whatever. So lie, too much, too long, too short, twist. So I think these are things that you have to have discussion with the surgeon. But I think there's no substitute of an excellent surgical technique to prevent that.
Yeah, and I think in my experience, and the most common cause of Lima to LAD failure is a vein graft to the diagonal. Like that's usually is the most common cause for Lima to, or at least early Lima to LAD failure. Dr. Rida,
if I can add, that we have a tool that will allow us to minimize the early graft failure by measuring the flow within each graft postoperative, perioperatively during the operation. And there are certain criteria that allow you to say this graft is patent, at least at the time of measuring, in which case the chance of that graft occluding perioperatively would be very low. Thank you.
I think, Dr. Al-Oakley, we have this discussion in every M&M round we have. I personally Doppler my graft once every 3 years. I think I tell people the best Doppler, the best is your eye seeing every single bite. Yes, you can have a noise now, a Doppler signal goes woof, woof, doesn't mean anything. You could be going backward, you could be going the wrong direction. I think it's those people who does, anastomosis doing the last 3-4 bites in one bite and getting, I think the best thing is a very sound surgical technique. And people ask me, why don't ask for Doppler? I say, because I see every bite to the end.
What do you mean? I think. What do you mean?
It's not only the bite, it's also the quality of your mammary harvest is very important. Exactly. If your assistant harvests a very poor mammary to you, it doesn't matter how good your bites are, the mammary wouldn't work. And that's why assessing these flows will be useful, I think. Thank you.
Well, before I anastomose the mammary, I make sure I have a brisk flow. Otherwise it'll be abandoned.
عادل بالنسبه لنا I have no idea شنو قصدك I see every bite يمكن توضح لنا.
The anastomosis, every bite in the vein and in the native circulation, when you do your anastomosis, those 12, 13, 14 anastomosis bite with a proline, you have to see every bite. Some would probably, you take 2 bites in the same, or especially at the end of the anastomosis. So I think what is clear, especially the anastomosis has a toe and a heel. The heel is toward the inflow, the proximal. The toe of the anastomosis is the distal, the one that is. So if you put a deep stitch in the toe of the anastomosis, which is the distal end, there will be no flow. And we see a lot of people putting extra stitch. They tack the epicardium on to put a pledget, pericardial pledget. Man, you're dealing with a 2 millimeter vessels.
Yeah,
that's it. You're done. You're compressing it externally. And I have seen people who have their chest tube sitting against the RCA graft. I always tack my pericardial tube into the apex with a 2O silk. My vein graft to the RCA to the PDA, there's no chance of my pericardial chest tube drain to touch it or suck it or do anything. So I do a lot of maneuvers to prevent this. I always slit my pericardium. I make sure when the anesthesists, they inflate their lungs, my mammary is under the apex of the lung. I've had colleague where as soon as anesthesia turned the lungs on, the mammary ripped. So the lie of.
Can you do that in MIS?
What's that?
Minimally invasive surgery. Can you do that?
I can do.
The top of the mammary is so far away from you.
No, I can't. When I harvest the mammary direct vision, I go until I see the subclavian. Exact same when I do the open. I medialize it. I go with the roll tractor. I go all the way with the extended cautery. There's no compromise. Exact same. I go to the first intercostal, that big branch. Don't worry.
محمد حميد قايم يبدا من بكري. We're getting close to 2 hours. يعني the discussion is شيق لكن we have to stop sometime. So نشوف الدكتور حميد شنو سؤال أو تعليقه.
السلام عليكم ورحمة الله وبركاته. مشكور دكتور عادل. Amazing presentation و amazing discussion. هو very basic question لكن a lot of debates. Differences between surgeons, but the question to Dr. Adel, what's your personal opinion regarding how to handle antiplatelet therapy before surgery? When I refer to you a patient with on aspirin and Plavix, would you stop both of them, or would you stop Plavix, and for how long? What's your personal strategy?
I will answer this question. This is the daily dilemma. Aspirin, we don't stop it even for outpatient. We no longer stop aspirin for any cabbages. Cabbage, any case, we don't. Anesthesia knows. The Plavix, actually, with the presence of ticagrelor now, البلافكس طلع حنين هلبة. البلافكس توا احنا وصلنا مرحلة إن مرات يعملوا لك حالة، يجيك anterior STEMI loaded with ticag, they stent the culprit, say RCA, and he's a left main. يقولوا لك والله we are switching him to Plavix and we're keeping him inpatient. Can you operate with Plavix on board? بس I don't care about the Plavix is a treatable. You can actually, it's a reversible. You can give platelet and you can get away with it. A TCAG, no way. I have to test the platelet. So the short answer, no aspirin. We don't stop. The Plavix, if I have the luxury of time, I would stop 2-3 days. Otherwise, I can operate on Plavix on. There's no problem with that. They also, I do platelet assessment before surgery and after. I do platelet assay. التكاج I don't touch him before 36 hours. ندير في ديلي لو تقول اليوم هو آخر دوز الصبح ثاني يوم أو العشية فاتت 24 ساعة ناخذ سامبل 5 cc ونبعتها للبرفيوجنست يقول لي you have if I have more than 50,000 functioning platelet I will operate on the guy. لو تقول لي patient balloon pump ولفت مين وقاعد في CCU young وقعدت تكاج عندي platelet sample أنا بعتها يقولوا لي في more than 50,000 functioning platelet I will operate on the guy. تقول لي 22 ولا 18 نقول لك سوري اللي كان بيموت انا حيموت مني في العمليات. بس I think the Plavix people are overinflating. I think there is a risk. I know there is a risk but you'll be surprised how many people I operate on Plavix والله العظيم ما تقول واخد حاجه اقسم بالله ما تقول انا واخد حلوى. No effect whatsoever. No bleeding, no platelet, no nothing. This is I think is inherited and known. 20-30% of patients are not responder. And I think this is one of the problems in the early trials relying on Plavix to hope that it will stop thrombosis. I think the variability among population responding to Plavix, unlike ticagrelor, 95% are responder. Plavix is could be on your side as a surgeon when it comes to operating.
I totally agree. الكلام مع دكتور عادل اللي قاله طبعا حتى نفس الشيء يعني الاسبرين وبلافيكس I don't stop aspirin and Plavix I didn't see any severe bleeding or coagulation problems in the operating room. If there is a bleeding we just transfuse 2 units of thrombocytes and everything will be okay.
معلش يعني في حاجه ثانيه لو انت disadvantage او advantage of off pump لو فتحت انا see the marrow is bleeding والedges is so oozy وكذا switch technique don't go on pump don't hypernize or go just do it off pump and minimize the risk of bleeding or hemodilution يعني في ways of dealing with Plavix عرفت.
الدكتور رضا شنو تعليقك على البراكتس؟
I will tend to agree with Adel and with Dr. Dries. However, if you are working in a maybe low income setup where you didn't have easy access to platelets, where you didn't have easy accessibility to reopening patients in the right time to save him from dying from tamponade, I honestly think there's no harm. I'm not really sure there's any data to show that patient, if you stop their aspirin for 5 days and then Plavix for 3 to 5 days, pre-op will have higher mortality preoperatively. As far as I know, there's no data. So it's better to err on the safe side, if you can, at least in Libya. Thank you.
في حاجة I would like to mention it, guys. I think there has been reviews. Leaving the Plavix leaving the aspirin at least on. المشكلة في cardiac surgery group that at least the one we deal with the elderly people, there is also apart from the cardiac ischemia, there's that gut ischemia, there's other ischemia that could happen. I think having some sort of anti-platelet activity peri-op, it helps to ameliorate these risks. And I just want to make sure I didn't, maybe I did not mention it. In my minimally invasive Cabbage, because the axis is small, those guys are usually by far, most of them are very stable. So these are the only subset of people that I stop both aspirin and Plavix. And actually in some of them I don't, if I'm worried about their symptoms, but these are the reason why, because when you work through a small port, even a little bit of dripping from the incision could be actually obscure your exposure. So I'd rather be completely at least 3, 4, 5 days off aspirin and Plavix. So that's the only subset of people that I would probably push for not having antiplatelet on pre-op.
عندنا كم patient
Just spoke about the graft patency, guys. This is very helpful approach to keep the grafts patent when you have aspirin at least on board, or is there some small non-randomized trials showing that? Definitely to keep the at least aspirin, preferably both, but definitely aspirin. The biggest thing is to keep the grafts open after surgery by giving them some antiplatelets.
I usually load my patient with 150 if there is no chest tube drainage more than 50 for 2 consecutive hours in the same day of surgery if I'm doing off pump. So that's my practice, is if I'm worried, or if you want to deal with somebody who had acute coronary syndrome, you've had a cabbage and you worry about the targets, I usually ask if there is no drainage more than 50 for 2 consecutive hours, load with 150 Plavix, and then tomorrow 75 Plavix.
That's for the patients with the ACS presentation, I assume.
Yes, or if I'm doing off pump.
Or off pump. Oh, okay, good. اوكي اعتقد يعني تورينا اكثر من ساعتين واحنا نتكلموا. ما شاء الله عادل عنده جهد في الكلام، يقعد حتى ساعتين ثانيه، تعرف ما عندهاش مشكله. لكن we have to stop somewhere. اكيد في اسئله كثيره ثانيه، لكن اعتقد يعني كانت نقاش شيق جدا. شكرا عادل على البرزنتيشن. دكتور رضا شكرا انك انت انضميت لينا. الدكتور حاتم والدكتور ادريس، وطبعا ما ننسوش نشكر ايمن اللي هو اللي خلانا نتلاقوا و have these activities. وشكرا للحضور جميعا والاسئله الشيقه لاثرت النقاش. وان شاء الله نشوفكم عن قريب. ايمن حط الاعلان بتاع المؤتمر الثامن لجمعيه القلب الليبيه. انا حنكون موجود، عادل حيكون موجود. نتمنى نتلاقوا معكم شخصيا in person. وحتى كان صار نقاش على البي سي اي فيرسس كابج، تحزوا بيناتنا يعني. ما
جيب اسمع، جيب معك جماعه من اسمع.
لا والله يا باسم، طبعا شكرا لك على النايس مودريشن وسوبر برزنتيشن. عادل ودكتور رضا حاتم مدريس اكسلنت كومنت. طبعا اسامه دائما يعني سبيشال كويشن وفيري براكتيكال. مشكور دكتور محمد حميد، وجودك ديما يسعدنا وسؤالك فيري براكتيكال. وعبد الغني حتى انت مشكور. نقطه يعني ان شاء الله حتى عبد الغني موجود معنا ان شاء الله، مجموعه كبيره جايه باذن الله، وهذه دعوه للجميع انكم تكونوا موجودين. ان شاء الله حتكون في عركه قويه في الموتور، مدارين ديبيت الليفت مين ريفاسكولايزيشن ما بين باسم الباروني وعادل. انا باسم اليوم حسيه كان ساكت هادي يلقط يشوف يطلع من يثبت معلومات من عادل
يجمع في المعلومات، يجمع.
لا اليوم يعني ما
اسمع ايمن. الفيلم 3 هلكاتا.
لا اسمع، عنده باك اب. لكن ان شاء الله حنديروا يعني اكسلنت ديبيت. حيكون الديبيت اوف ذا كونغرس، هذا ليفت مين. لكن حيكون ان شاء الله مجهزين برنامج علمي معنا طبعا، حتى الدكتور اسامه البهليل ودكتور محمد حميد في اللجنه التحضيريه. فان شاء الله لو طولتم من هنا لشهر 7 يقول كيف منعاش، لكن المجموعه يعني كأن خليه نحل شغل ليه باذن الله. حنديروا حاجه تليق بتاريخ جمعيه القلب الليبيه، تسكرت 20 سنه، تاسست في 2002. فيهمنا وجودكم. طبعا تسجيل عن طريق الموقع الجمعيه. يا ريت اي حد يبي يجي، يا اما بيشارك بمحاضره، بيحضر، حتى يكون معنا في الاكسبيرت بانل، يبي يعطي برزنتيشن. الدعوه مفتوحه للكل، نبغى نكون انكلوسيف. فيا ريت تبعتوا لنا وتسجلوا في الموقع. تسجيل بسيط، لو انك انت عضو جمعيه القلب الليبيه الحضور مجاني، ومجرد لما تسجل اسمك نعرفوا العدد اللي بيجي، فنوتوا كل شيء يعني بطريقه علميه وصحيحه. والناس اللي جايين الزوار من برا مدينه طرابلس نساعدوهم في السكن ان شاء الله. فكل ما تتعاونوا معنا كل ما نسقوا لحاجه في المستوى ان شاء الله. وماذا بينا يعني حين كل لما الخبرات الليبيه من دكاتره وتمريض وجراحين نكونوا موجودين في مكان واحد، الفائده حتعم لمرضانا ان شاء الله. وزي ما قال البتري عبد الغني في كلمه عجبتني، ان هي مش كابج فيرسز بي سي اي، هو زوز. احنا وي ورك از ا تيم. التيم ابروتش تكلم عليه عادل مهم جدا. وي اوفر واتس ذا بيست تو ذا بيشنت. هي از نوت اباوت وات اي كان دو، اتس وات ذا بيست ثينج تو اوفر تو يور بيشنت. فمشكورين ومشكور جدا يا باسم على النايس مودريشن وكل الحضور. شكرا جزيلا، وسجلوا في الموقع الجمعيه.
بالله عندي سؤال لو سمحت ايمن، هل ممكن في فيرتشوال لاني ما نقدرش نكون غادي، يعني هل في فاسيلتي يكون فيرتشوال؟
والله حاليا حيكون ان بيرسون، لكن انت عارف الاي تي في ليبيا في
شويه،
لكن انا الدكتور محمد حميد واسامه مش عارف قاعدين ولا لا.
لكن اللي يا حاتم كان ما تجيش راه
والله
دكتور محمد حميد، بحكم انك انت من اكثر الناس اللي كانوا من اورجنايزنج كوميتي في مؤتمرات الجمعيه، هل تعتقد ان حيكون في امكانيه انه كان جزء من فيرتشوال؟
بنزرد بباسم وبنمشي القربوا لي بعدين.
طلعك حتى صاحبك مش جاي معك يا عادل. ها عليك قعدت بالراحه
في نهايه 7 خير.
لا ان شاء الله دكتور رضا حتكون معنا ان شاء الله موجود.
ان شاء الله وانتم طيبين باذن الله. انا شاكر جدا على fantastic session, very great presentation by Adel as expected, and for the chairmanship and for the European Cardiac Society for really making this a beautiful event. Thank you very much indeed. وهنتلاقوا ان شاء الله ممكن قبل 7 وفي شهر 7 باذن
7 جولاي 1st 2nd 3rd ان شاء الله. وحيكون في ورك شوب قبلها يعني بيومين 3، لكن ان شاء الله البرنامج كل العلمي كله حيكون الفتره الجايه. وقلت لك يعني we're looking forward to meeting all of you. نبغى نتلاقوا ويعني في حاجه ل spread the knowledge وshare الاكسبيرينس والاكسبرتيز we can all learn. في الاخير هذا يرجع لاهلنا وناسنا في ليبيا. السلام عليكم بالنسبه لي.
ماشي الحال، بارك الله فيكم. بالنسبه
بارك الله فيكم.
شكرا جميعا على الحضور ونورتونا، وان شاء الله ربي نتلاقوا على الخير ديما. يلا تحياتي. السلام عليكم. سلام.
شكرا جزيلا. السلام عليكم.